And now we are live on the other side as well.
I believe we're live on the United Medical page.
From Tanner, from your side, I'm hearing echoes, or it was from, okay, never mind, that was from my side.
It should be okay. From me.
All right. So we are going to go ahead and start. Today is January 25th, no, 22nd actually. January 22nd, Friday. This is our weekly session. We are going to cover a couple of our regular items as well as some of the new items. We had discussed last couple of weeks, that we had some of the issues that we want to kind of explain in a better way to the public. Again, my name is Kemal Erkan. I'm the chairman of United Medical ACO, and I have Tanner Fuchs with me. And Tanner, if you can also introduce yourself, please.
Sure, my name is Tanner Fuchs, a member of the business development team here with United Medical.
All right. So, well, we'll start with our COVID updates. Today, we are going to discuss, other than the COVID vaccine numbers, we are going to also discuss the rollout issues and also representation from private medical practices and why we are actually having this discussion, why it's important for the public, and we want to have a constructive way of building what we want to accomplish for United Medical and the patients of United Medical, as well as the residents of Delaware. So that's kind of our main goal here. And just going through the numbers that we have, we are at 420,530 total number of people who lost their lives. Total confirmed cases, a little over 25 million. This is the part that I kind of like to actually show you the real data. Real data meaning that actually real-time data from Worldometer. Part of the reason again is because we do like to see the trend and where we are going. 2 days ago, 4,400 people lost their lives with 190 new confirmed cases. And yesterday we were at a almost same 63 total number of people who lost their lives, and about 194,000 new confirmed cases. As of today, this time, we are at 28,000 confirmed cases, but because this is the real data, real time, it's updated. So by the time it's end of the day, it's going to be close to probably 180, 190,000 range. So we also want to share the Delaware numbers from here. And then those are in our PowerPoints, but I think just kind of seeing the trend is important. And hopefully it does help everyone to understand these numbers in a better way. And let's see what we have as of this time. So sometimes I'm worried that I'm not sharing the right screen. So okay, so I'm on the good side here. All right. So the hospitalization, this number is, it's kind of similar to the last several days. Right now it's at 448. Yesterday it was 456. New admissions are a little bit lower. Yesterday and the day before, the percent of person testing positives, we are at 23.8%. And when we look at that for the percent of tests that are positive, it's about 9%. So that's where we are with the Delaware numbers. Now, if you're a telemarketer and if you're calling me when I'm doing a live session, you know that we'll never buy anything from you, so don't even bother calling, right? So, all right, so let's go through our numbers here. Now, Tanner, tell us about what's happening from the United Medical side.
Sure. So these numbers are numbers we've been going over for the past few weeks now. We want to make sure that our patient population, anyone in the state of Delaware who may be tuning in, is aware of the orders that we're putting out for the COVID vaccine, or not for the COVID vaccine, sorry, for the COVID tests within our patient population, as well as the results we're getting back. So we've been keeping an eye on our trend. We saw a little bit of a spike there as we got into the holiday season around the 25th, end of December, early into January. So we're still kind of around that height we saw, right around the 28, 29% test positive. We're starting to see a little bit of a dip. It's still a little early with resulting those tests. Also, we're optimistically cautious, I would say, that we're seeing that number early for this past week being slightly lower than it was in the past few weeks. We are seeing a little bit of a drop in the amount of tests. So far we have 100 in for this past week. You can see that there on the right side. We did start to trend back towards that goal. We still have that goal set at 300. It's always good to be able to get more tests out so that we really understand how the virus is spreading in our patient population, or how it has. So we're keeping an eye on the numbers of tests as we continue to move forward. With our patients that are testing positive, we're also doing, as we've mentioned, business development team and I are following up on, along with the practices and support with our practices, the test results that are coming in for any outstanding COVID tests that have been placed, but the results might not be coming right back into the chart. We're trying to follow up with these patients to see if there's any hurdles to getting tested, or if they're even getting tested at all, which was unfortunately something we were seeing, that patients would have to order but not get it fulfilled. So that's what we wanted to keep track of. We call that our positives and potential positives, because every time we have a test that's ordered but it's not being fulfilled, that's a potential positive out that we're just unaware of. So thankfully, we see that indicated here with our yellow and blue bars. Blues being patients that we just were unable to get a hold of, or that they decided to not get the test. And our not needed is pretty much similar in the same fashion. It's just patients that said that they felt like that they didn't need to get the test done. Maybe they said they were feeling better, or symptoms didn't persist. Well, we still want those patients, of course, to get tested, as it doesn't hurt. It's always good to have the most accurate data. But we are seeing most of our patients for the past week. I think a lot of those are resulted at this point. And we were able to get a test result back for a majority of those. And we're already seeing with the early outreach this week, past week, Kemal, that most patients are getting their tests completed.
Oh, that's really good to hear, so that people are getting their tests done. Mm-hmm. So now we have some updates from the COVID rollout. Now, we are going to provide this side-by-side comparison, so that anytime you need this, you can actually go back and then just see what the differences are between these vaccines. Most people already know between the Pfizer and Moderna. We added J&J here. They are not used so far yet. They're on phase 3. Tanner, what's going on with them? What's the latest update on them?
Right. So as you mentioned, Kemal, they are wrapping up their phase 3 clinical trials. So we're seeing a little bit, the information we're seeing here is based off the results from those trials. So far, very similar in a pattern of side effects that we're seeing. Really, with the only addition was the fever in the J&J was a little bit more relevant than the other two, as we hadn't mentioned that it was very rare occasion that was happening for our Pfizer and Moderna vaccines. Like you mentioned, these are the two that are being distributed right now, so we're pretty familiar with them. But we're keeping an eye on the J&J Johnson & Johnson vaccine, as another big difference in addition to that side effect is this is going to be a one-shot vaccine. So I know even as of yesterday, I believe if you were able to catch a little bit of Dr. Fauci's last task force conference, he was mentioning how we're really optimistic for this one, as it could be a pretty big game changer in how we tackle the vaccine spread with vaccines. One shot would be a large difference from what we're already seeing already. So logistically, that could prove to be beneficial.
So just so that we make sure that everyone is on the same page. Now, with the different, like the 2 shots, you have to maintain and you have to have a certain number of doses available for the second dose, and then also it's operationally it's difficult, right? So the 1 shot would be a lot smoother, and we wouldn't have those issues that we are having right now. Now, I don't know what the J&J's storage requirements.
Yeah, that's still an area I was trying to find, Kemal. I was having a difficult time locating like a precise, correct answer. So we'll keep an eye out on that type of information, as well as the efficacy. So it would be beneficial to note that right now with those phase 3 trials, obviously not finalized, but they're also seeing a 90+% effective rate at preventing symptomatic COVID-19 cases.
All right. So one of the issues that we see, Tanner, the different numbers that we get for vaccine rollout. So what it means is that, so we go to the state of Delaware website, we have one set of number. Then we go to CDC website, we have another set of numbers. Then we look at different places, they all report different things. So let's actually just review what these numbers are and then why the discrepancy is happening as far as what we know so far. So this is from the Delaware side, right? So
correct.
Go ahead.
Yeah, so I think that that's important to note. So from the state of Delaware, this is data that we're tracking from their website, the coronavirus delaware.gov. They're keeping track of the amount of vaccines that are being allocated to the state, as well as that those have been able to be administered. So of course, we're going to see a little bit of a delay from numbers that they're reporting, as it's not going to be simultaneous. I think that's something we all should have to remember. As a vaccine goes in to an arm, it's not automatically going to be updated at the state level. That's going to have to be reported to them by whoever is actually administering. So they have, as of this morning, I believe these numbers are showing right about 54,760 coming from the state that have been administered out of their roughly 90,000 doses that have been delivered so far. So that leaves about 34,000 in storage that are available. And Kemal, I added this graph here at the bottom just to kind of show, I think this is going to be a helpful visual as to where exactly are with the total amount of vaccines. So I liked the line graph because it shows that we're staying roughly at about the same level of doses coming into the state over time. So right now we're kind of like at, not a huge slope here. We'd like to obviously see more vaccines available, but this is where we're at currently.
Tanner, we are going to probably connect this piece to our last part of our discussion. So now we, as United Medical ACO, did not receive our vaccines until last week, and that was the 14th, right? So it was somewhere around here. So we could have gotten that here, and we would probably just get to this point somewhere by December 24th or December 28th.
Yeah, so I think that's
one of the points that we're going to make later on.
That was another reason I did want to include this as well, because you can see, as you mentioned, and we'll get into it in a little bit, where our phase 1A for our medical staff was really just taking off this past week. At that point, the state had already received close to about 40,000 doses.
So now CDC says, the Delaware website says these are the numbers. When we go to CDC website, these numbers, here's for Delaware. This is as of last night. Total distributed is about 106,000. Right. And then total doses administered is 49.
So that's a little different, because this is from the CDC. They're showing more, roughly about 15,000 more doses distributed, but about 6,000 or 7,000 less administered. So that did kind of was a little curious. Yesterday, I know we were kind of reviewing a little bit of this data. Now, my only thought would be, obviously the CDC, as on a federal level, has a little bit of a quicker access to the number going out, but maybe they're having to wait on those reporting delays from the state for the doses administered.
So I do also want to play this video because we discussed the situation with Dr. Fauci. So I have a little bit mixed feelings on this, but let's see if I just want to make sure that if you guys hear it okay. I'm just going to make sure that I'm sharing my.
I can see the.
Yeah.
Yeah. I can't hear it though.
A few holdovers from the previous administration to this current one. What has been your experience with this new team? And in your view, what would have been different in terms of the trajectory of this outbreak from the start had a team like this been in place at the beginning?
Well, I can tell you my impression of what's going on right now. The team, I don't know if I can.
So the part of the, the question was kind of like, I'm sure most people already saw this, but they're asking him how he feels about the transition pretty much. So let's see.
Extrapolate other things, but one of the things that was very clear as recently as about 15 minutes ago when I was with the president is that one of the things that we're going to do is to be completely transparent, open, and honest. If things go wrong, not point fingers, but to correct them and to make everything we do be based on science and evidence. I mean, that was literally a conversation I had 15 minutes ago with the president, and he has said that multiple times.
You've joked a couple times today already about the difference that you feel in being kind of the spokesperson for this issue in this administration versus the previous one. Can you talk a little bit about how much different do you feel, less constrained? What is the, you for so many times you stood up behind the podium with Donald Trump standing behind you. That was a different feeling, I'm sure, than it is today. Can you talk a little bit about how you feel kind of released from what you had been doing for the last year?
Yeah, but you said I was joking about it. I was very serious about it. I wasn't joking. No, actually, I mean, obviously, I don't want to be going back, over history, but it was very clear that there were things that were said, be it regarding things like hydroxychloroquine and other things like that, that really was uncomfortable because they were not based on scientific fact. I can tell you, I take no pleasure at all in being in a situation of contradicting the president. So it was really something that you didn't feel that you could actually say something and there wouldn't be any repercussions about it. The idea that you can get up here and talk about what you know, what the evidence, what the science is, and know that's it. Let the science speak. It is somewhat of a liberating feeling.
Basically,
for a few months. I have a different feeling about the way this came out. So when someone is in charge, they're in charge. So nothing changed from the admin standpoint. So I actually, if someone is dissatisfied with something, then he should have left the position because he's 80 years old. He doesn't need this job. He's a physician. So physicians are not used to being told. So that's why we also respect them more because their education, their autonomy in what they do. I was hoping that he wouldn't, if he was this unhappy, he should have left that position because everything that's coming from the time of the last 12 months or 10 months, we didn't inherit it from somewhere else. It's just same people are doing the same thing. So we don't want people to use excuses for now what's not going to happen in the next couple of months. We don't want people to use those as an excuse saying that, oh, well, we couldn't do this, we couldn't do that. We didn't know any of those and we should. And this is not China. Why did he not come out and then just tell us he was under extreme pressure? Because something could have been done differently if that was the case. But I still kind of like him, so I'm not going to go too much after him, but I hope that didn't come out or that didn't sound the way it did. So I don't know how you feel about that, Tanner, but I don't want to put you on the spot.
That's all right. I just hope that going forward, they are able to continue to hold those meetings. I know that they're very beneficial, and having that public face is going to be more crucial than ever as we go forward with the vaccine rollout.
So now we are going through the transition from the 1A to 1B, but 1A doesn't mean that it's completed, right, Tanner? So we are still doing that.
Yeah, that's correct. I think that that's very important to note. Although we are officially transitioning into the phase 1B, where now persons 65 and older, as well as considered frontline essential workers, are going to be eligible for vaccine. That doesn't mean that phase 1A is necessarily complete. That's reason for a number of factors we're seeing, Kemal. I think a big one being vaccine education, which is something that we're talking about and actively putting some material together for. We want to make sure that everyone has all the resources that they could possibly have available to them to make an informed decision and to get vaccinated. I know it's something that we have discussed previously. We have resources and videos available for. But as we are moving into phase 1B, that's right. It's a new population is now eligible as we're moving along, but anyone that would fall into 1A is still available for vaccine as well.
Well, so United Medical ACO received the first vaccination, first part of the vaccines last week. This is for our medical staff. And I have to make sure that I acknowledge and recognize Hazel Bimat, one of our practice administrators, her efforts in putting everything all together. I know a lot of people were helping, but without Hazel, it would be extremely difficult. And I cannot thank her enough. So I did want to actually bring this up, although she did not. She wasn't really happy about us sharing her picture, but we did it anyway. So yesterday and the day before yesterday, we had our surgery center, American Surgery Center, our medical staff, they were vaccinated there. Again, we had about 170 total completed in 2 days. And we are very pleased with the way that our people were able to complete this. Michelle Ciano, our director of nursing, Melissa Dimat, she's another practice administrator. So they did extremely well. And again, thank you for what they have done for us. Now, one of the reasons that we want to share and actually do these live events is because we have issues. So we have issues because we are in business, and then we want to actually address these issues. And since we have this platform now where we are able to share certain things with our people in Delaware, we also want to discuss some of our issues on the provider side and the understanding of how state is important, the state of Delaware is important. And when we say the decisions are being made, are we like part of it? Are we aware of those decisions? And do we want to be part of it? So, and the answer is yes, yes, yes for all of them. But we just want to actually structurally educate everyone, including myself, just so that we have a better idea and then why we want certain things at the end of the day. Now, Tanner, we prepared this together. So this is Delaware Healthcare Commission, and this is the highest healthcare committee in Delaware. So the mission statement is, tell us what you see here.
Sure. So that's a great point. Just first and foremost, that our goal here is to provide the education to our patients to Delaware, and even to learn a little bit something on our own. So going through this, I was learning a lot as well about the healthcare commissions and the committees and representation on these. So looking and reviewing some of the information prior for our discussion, we wanted to take a look at the Delaware Healthcare Commission and their mission statement in particular. And that is the Delaware Healthcare Commission wants to foster initiatives and implement programs to really try to promote high quality, affordable care for all Delawareans, and to particularly through a collaboration of private and public sectors regarding healthcare. And as you can see here, just looking at some of the like goals. Oh, sorry, I wanted to kind of talk a little.
Go ahead, sorry.
I thought it was really interesting that they laid out their responsibilities and their goals, particularly with that collaboration between public and private health sectors. So yeah,
Tanner, the part of the issue that we have here is we are not part of these committees. Some of these are appointed by the governor. Now, this is one of the examples. This is the DHCI board. It's one of the sub committee or sub board of the main one. When I go through the list altogether, this group, total number of people, I believe there were 18 total. Christiana Hospital and Christiana affiliates, meaning that it may be their lawyer that they work with, it may be their funded other nonprofit organizations they may be part of. So that's what we see at 40%. There is this is one board. So in one board, 40% of the board is representing Christiana Hospital's interest. Then we have rest of some of them are assigned by it's just an executive job for them, and then there is no representation of private practices. So, and this is not so. If there's a new insurance company, let's say if there is a this group, let's say right now Mary Health and Health Option, on top of Blue Cross, they actually Health Option can have someone on the board. And that's kind of like automatically assigned. Then Mary Health is a new player, new as like 2018, 19, 20. And from day one, they are part of the board. Well, we have United Medical ACO and we have Aledade. And when we look at the layout again, the infrastructure of the physicians, we want to see how this is actually kind of like divided. So there is the hospital employed groups. And then we use the Christiana example here because hospital ACOs are mainly under Christiana. So it wasn't like we were picking on Christiana. And then on this side, we have three groups. We have United Medical ACO, we have Aledade, and we have some private practices. Now, I have to tell you, I actually went through, I attended a couple of the state sessions for the private practices on Wednesday nights. It's a disaster. We share some of them, just like a time travel, going back to 1967. Have your ice cream and have your milkshake, or have just whatever at charcoal pit, and then just drive your big American car through the some movie like outdoors. It was crazy, right? So like it's a time like if you're interested in that, you should come and join to those calls. We deserve better. We deserve better in so many different ways. We deserve better because we are the first that patient is in contact with. Patient-centered medical home, the concept of that is based on primary care. And then with the specialties on top of it, on the private practice side, it's extremely important that we keep this part of the business live. Like if they are not, then they are going to become employees of the hospital system. Now, if you are not working for one of these guys, and then if you are just someone from our Delaware, state of Delaware, you may say, you know what, why do I care about this? And I can almost hear that. Well, we also want to kind of tell you why you should care about that. Now, number one, we have a big infrastructure under United Medical with almost 117,000 patients, unique patients, individual, they're not like they're any duplicates, 428,000 appointments in 1 year. So this infrastructure is supported by United Medical ACO, and this group has almost zero representation in the decision-making of healthcare. How inefficient and unproductive that is really crazy. Now, we had a governor who used to be the congressman at the time. This is from April 2010. It's one of his emails to me, and we are going to try to work with him in the near future. but this is the governor that I miss, where he was interested in the private physician's interest, and then he would be able to come to our offices. He would meet with me and with our providers. That time, John Carney was a congressman. So now this is again April 2010. Now, this is his email to me. It's pretty clear that we had this communication channel open. So the communication is key. So if I lead the group of almost 200 providers, and if we have a way of helping our people in Delaware, not utilizing this properly, not timely, that's just not helpful for anyone. Now, I'm going to take you guys from here with the triple aim goal. What's triple aim? Is improve health, lower cost, and better care. Now, I want to take this one at a time. Now, there are three main elements, right, Tanner, here? So if the three main elements, if one of them is the cost, for us to not support accountable care organizations, it will be almost criminal. Because look, I mean, this is United Medical's how we kind of align ourselves with the state requirements, accountable care, reduce costs, and improve health. So now, why do we care, and why should public care about this? As we are not able to stay in business because hospitals are putting a lot of pressure on us financially and other reasons. I mean, that's not true for us, but I can see for other private practices, right. They will be employed by the hospital. So, and then when someone is employed by the hospital, now so-called nonprofit organizations, right now, Christiana Hospital is running about 110% profit margin on lab services, 110%, 110. So,
yep. I think that's an interesting point. Could you, and this is something actually that I was a little unfamiliar with beforehand, but as we started to have these conversations and look into this information a little bit more, something that I think, and this might go for a lot of people who may be listening, that's a really interesting point because they are a nonprofit, correct? But we see this stark or large number in profit margins that we're seeing. Now, could we just go into that a little bit further? Like, where does this come from? How is this possible?
So, this may make it easier. So because they're nonprofit, their tax returns are available. They can come in, if anyone challenges these are public records. You just need to know where they are. I mean, when I was 23, I didn't know where they were. So now, this is Christiana Hospital. There are three income sources, one from the operating services, one from the lab, and one from the outpatient or the patient care services. So I just want you to look at these two. This is the profit margin year by year, and the latest available is the fiscal year 2018. They made $118 million for surgical from the surgical services. Right. It's running about 45% profit. Now, more interestingly, I just want to make sure that this is kind of like visible. So these are lab services. I took this from their tax returns. This actually, we were just updating this last night. The cost goes up, and again, I'm using the same line items that they have, Tanner. So from the lab services, that's about 100% profit margin. So here, like 78 million, when the cost was 80 million to them, that's 98%. So well, I'll tell you this, if you had these numbers for our private practices, I will be the richest man in Delaware. And it's not the case. So now you go and get a gallbladder surgery. This is, I think we took this from my article, right?
That's correct. Yeah, those were both helpful. Or as we were preparing for this conversation, yeah, I thought it would be helpful to go back and read through some of these. So I grabbed some of the more some points from there. Mm-hmm.
So, Tanner, the issue was when we started the United Medical ACO, we were first with Medicare as the MSSP. So the goal is decreasing the cost. So then we get our public data, and that was the first time that was available to us. So I own a surgery center, American Surgery Center. I'm one of the owners of American Surgery Center, and I do gallbladder surgery, which is pretty common. It pays $2,000 something, and same procedure averaging by Medicare in one of the hospitals is $12,000. Same doctors. Well, you may actually get some residents operating on you too, and $2,000 versus $12,000. So that's how it started. Then I just going into these a little bit deeper to see why, like if you look at the most money is spent from the lobbies. Hospital in Delaware is by far they have the most money and they spend the most money on lobbying. Why would hospital lobby? It's a nonprofit organization, right?
Right.
This is healthcare. What are we lobbying for?
Sure.
Make things more expensive? Well, kind of.
Right.
So, I mean, I have some more details on those numbers. Now, just so that we want to stay focused, and I don't want people to feel like we are maybe attacking some organizations. This is not our goal. Our goal is we want fair, equitable representation in our decision-making process in the state of Delaware. So that's kind of like, I don't care about any of these organizations if we were treated equally.
And that's something that with that chart, it's highlighted. I think I even had a spot for our ACO representation as well. But it looked like just from reviewing those numbers, it was about half for the hospital system, about 40 of that being from Christiana and Christiana affiliates. Although we just,
it should be illegal. It's a monopoly.
I think that's something you discussed a little bit in the latter part of the second article.
Right. So it's just like it makes it so difficult to operate for. And then, in some cases, now, if the private practices, now one thing that's really important, I do believe that clinical integration has to be there. Financial integration to a point has to be there. Now, the reason we were able to successfully administrate so many vaccines, we did the same thing with the flu vaccines. Now with the COVID, is because we have infrastructure. So when Surgery Center was doing what they were doing, we sent several people from the business office to help. Same thing with United Medical Clinic the week before. So private practices, they have to really get organized, and then they should be under some clinical integration planner. The part of the issue is I see some of them being part of the problem too. So we just want to make sure that we are not, we actually refuse to be part of that. We have you are part of almost all the meetings that we have. Well, how many meetings we do with our providers every week, Monday night and Thursday night, 6 p.m. Regardless of what happens, we have those meetings. So we have the infrastructure and we have the outcome. So here's what I would like to share. This is again from all public data, right? So I sent these to Tanner last night, and he was nice enough to put these together for me. So there's 3 hospital systems that I have, and this is overall rating, patient surveys. 2 out of 5, 3 out of 5, 2 out of 5. Well, here's American Surgery Center. I have 100% patient satisfaction in the last 12 months. And I do most number of bariatric cases in the surgery center in the state of Delaware. So they're not like just the colonoscopies and EGDs. That's 100%. Okay, 100%. 60% or 40%. Well, now going back to this puzzle here, lower cost and better care and improved care, well, we have them all, not at the same level, we have it at a better level. We are not promising, or we are not providing same level as the hospitals. We are taking the game to a different level. So I'm not going to stay at the, like, they have their own challenges, like teaching hospitals. Well, teaching hospitals is so good, right? Well, they get paid for it. I mean, Medicare pays them for each residence every year. Number one. Number two, they bill for those services. Number three, someone gets those services. So it can be you, it can be me, it depends on the emergency.
Some of us.
It's not like they do it for free, right?
Right.
So, but if the triple aim is the goal, and if we already demonstrate that we actually have done it better at very low cost,
right,
then patient satisfaction is at 100%. So what are we missing? Right? So what is it that we are not, why are we not good enough to be treated? So I was trying to put one of our surgeons on the board of the DHCI, and we got the objection from Christiana Hospital members. Why? I mean, ACO needs to be represented, and Christiana did have enough people there to make that objections go through. Again, we have
so the representation matters there in that sense.
Of course, right? So it's all about how you can, and that's why we take our time to do this session. So we don't get paid separately for this event. This is part of our business, although we are trying to get some sponsors. So so this, on the second part of the article that I have written, I think it was 2 years now. It just tells you like how this is all about hospitals with expensive services, complicated, like sending patients to the hospital for vaccine is criminal. So
yeah, and I think that's highlighted there, in that to kind of go to that third part of the triple aim to improve the health. I think that's what we're seeing now. That's the stark reality there. With improved health can come through part of that triple aim with the lower costs and the quality of care. You mentioned time and time the infrastructure is there, as we've shown. I think that improved health starts with preventative care. It starts in the primary's office. And I think that's the missing key right now. I think that's a good point.
So that's kind of like why we are bringing this up as part of our
it's important.
Our weekly communication. Now, we do want to remind our patients about the patient portal and utilization of the portal. If you are upset with the phone call and waiting on the phone, you are not going to get anywhere. Use your portal, please. Like, it's the easiest on your phone, on your iPad, on your computer. For something that you have to read for 20 minutes, you can just do it in 10 seconds.
And now more than ever, Kemal, the portal is going to be really helpful for, let's say you do get some of the COVID tests, you can view your results right there. And as we move forward in the rollout too, it'll be a good way to receive communication. I think that those are two important points as well.
All right, so this week we have one more event. This month we have one more live session next Friday. And then our Wednesday wellness webinar for our diabetes group. It's the second and the fourth Wednesday of every month. So that means
there will be one this Wednesday. Yes,
right?
That's correct.
I actually do enjoy those sessions. I learn a lot from Amy. And I share some of my own experiences. So then it's very useful for those. Now, how are we doing with this event, Tanner?
How are we? Well, the bariatric ones have been extremely successful. So we've gone into, I believe it'll be the third one of the year. But overall, from the bariatric webinar, seminar, and our support group, All right. What's that number?
Fourth one.
It's the fourth one. I apologize. The number, I forgot to put the number there to remind myself. But overall, we're coming in near on 70 events, I believe.
Yep.
So they've been very successful, and I think being a part of these, even to your point with the diabetes one as well, neither necessarily pertain to my patient demographic, but each time I tune into these, I do learn something new. So I think that's a good point, that it's good for everyone.
The part that's, again, just going back and then just closing, wrapping up, we are going to share the COVID updates on a regular basis, but we do have an agenda. The agenda is anything that public needs to know about the healthcare system in Delaware. We are going to make that available to you. Everything that I know about healthcare, you are going to know about it because it's important. So you pay for it. Our patients pay for it. So our citizens, our residents pay for it. So because everyone pays for it, then someone has to be accountable. So we are part of the system, but we are not going to be, we are not okay for not being part of the decision making. And we want our voices to be heard. We want our private practices to be represented. It's a huge problem for us. It's not going to go anywhere. So, until that happens, you're going to hear me every week talking about this. At some point, you're going to see this and you'll watch it anyway. So now the vaccine rollout, again, is extremely important. I got mine last week. I mentioned my first dose. The second one is in 2 weeks. All the providers receive theirs, almost 200 of them in our network, just in Delaware. And then some of our medical staff is done. No major, nothing actually that's important as a side effect. Some of them we knew already. If it's available to you, getting your vaccine is extremely important. Please try your best to get it. And you use your patient portal. And then subscribe for our channel so that you get your updates right away. And then we'll see you next week then. All right.
Good.
And thank you for joining me again.
Of course.
Next week.
Great. Bye-bye.